Nigeria recorded the first case of Ebola virus disease on the 20th of July, 2014. For the first time, the disease escaped isolated rural villages where it first appeared in Guinea and spread across borders to Sierra Leone, Liberia, Senegal, and Nigeria.
My name is Dennis Aka. At the time, we knew nothing about Ebola. We were just hearing Ebola in Liberia, Ebola in Sierra Leone until that day. But even at that, we didn't get to know until 4 days later.
For the first time, Ebola virus disease challenged world public health systems, exposing gaps in emergency response strategies. As world leaders and public health specialists scrambled to control the outbreak in West Africa. In Nigeria, public health teams mobilized and put minds together based on many years of experience working on various infectious diseases. The Nigeria Field Epidemiology and Laboratory Training Program, a 2-year training program in applied epidemiology, hosted the first Ebola Rapid Response Coordination meeting on the 23rd of July to develop terms of reference for a rapid response team, case definitions, and plan of action for the outbreak. The EOC was formed jointly with the Federal Ministry of Health, Centers for Disease Control and Prevention, and the World Health Organization. Residents, faculty, and graduates of the NFILTEP were keenly involved in the investigation and response of the outbreak, coordinated through an emergency operations center in Lagos. A total of 100 residents and graduates participated. The Ebola teams set out to do surveillance and contact tracing in the 2 affected states of Lagos and Port Harcourt.
One of the key things I learned from this outbreak was all the team members had to be extremely committed to each of their roles, because we had different teams and they all had roles. You know, we had to be committed to our roles, to doing what we were there to do. For example, I was in contact tracing, and we had to make sure we traced every single contact. Sometimes I would have to go 3 times to make sure I get a contact that day, because you know the mantra was you have to see them every single day.
All the stakeholders came together and they formed the EOC, and it involved multidisciplinary teams. And of course there was the epidemiology team, and part of the epidemiology team was the contact tracing team, and that was where most of us from NFILTEP were involved. We're involved in registering the contacts, following up all those who had contact with that primary case, and then of course identifying as early as possible those who eventually came down with the disease and getting them as quickly as possible to isolation center to prevent possible spread of the disease in the state.
Dr. Adebola Olayinka, Laboratory Resident Advisor NFILTEP, who supported the response to the Ebola outbreak in Kenema District in Sierra Leone, supervised case management and the emergency operations centers in Lagos.
Case management team comprised of 5 subcommittees. One of the committees was the psychosocial committee, and that was important because they needed, apart from the fact that the patients were sick with Ebola, a lot of them were psychologically affected, either the depression of why me, why should I have Ebola, and all those things. So you needed a psychological team to manage that psychological aspect. The social aspect, because there were needs. People were picked up with almost nothing and taken to a ward. And they needed clothes, they needed basic things, toiletries and all that. So the social aspect supported that social need. So we had them as a joint group called the psychosocial team. Apart from the psychosocial team, we also had the pickup and the contamination team. These were the people who would go and pick up a suspect and bring them to the ward, and at the same time they decontaminate the premises from which they picked up the suspect. We had the burial team also under the case management team, and these were people who were responsible for safe burials of patients who died from Ebola virus disease. Then we had we call them the IPC team, that's the Infection Prevention and Control team. And the IPC team did a lot of training on infection prevention and control, training healthcare facilities, training healthcare workers to be able to identify suspects and know how to triage for Ebola suspects. when people visited the health facilities. Then we have the clinical team. The clinical team comprised the lab, the clinical team itself, which took care of patients in the isolation unit, and also the triage unit. So the case management comprised of these 5 teams.
The first cohort of 13 NFLTEP residents who began their training on the 20th of October 2008 completed in December 2010. The program has so far enrolled a total of 262 residents since. Residents and graduates of the NFLTEP championed the conduct of 3 operational researches in Lagos State, which provided information that guided interventions to control the outbreak. These included a community-based study that assessed the knowledge, attitude, and practices of community members regarding EVD, a health facility-based study that assessed the level of preparedness of health facilities to manage EVD, and another study that assessed the psychosocial status of EVD cases and contacts.
There was so much confusion and panic in the air. It's an outbreak we've never experienced before. So there was so much on guesswork and fear. Fear was actually palpable in the communities across the nation, and you could see people literally consuming salt with water, and people were actually behaving below the knowledge they have. So we thought objectively we actually need to assess what the community know, what's their attitude towards this outbreak is, and what are they actually doing. And why did we do this? Number one, to have an objective documentation of what is going on. And we didn't restrict that to the communities, especially in Lagos State, where we had it initially before we had another exportation to River State. So we did a research in the community and also in the hospitals in Lagos State to know what the health workers actually know. It's something to know something, it's something else to do what you know. And how grounded were they in case they have another case, what will they do? So we conducted 2 major research then in the communities, in the local governments in Lagos State, and then in the health facilities, tertiary, secondary, and the primary health care centers. 3
researches were conducted during the outbreak in Lagos by the Operational Research Unit of the Ebola EOC. The first one was on public assessment of public knowledge, perception, and source of information on Ebola virus disease. The second was assessment of the level of preparedness of healthcare workers.
Nigeria, being one of the 3 countries still fighting the polio epidemic, it has set up strong polio surveillance systems supported by the Polio Emergency Operations Center. When the Ebola outbreak occurred, it was crucial that Nigeria utilize the same systems to enhance surveillance. The well-established surveillance systems, rooted at the grassroots, was a major tool used for coordination and surveillance during the Ebola outbreak.
When we had an outbreak of Ebola in July 2014, because the program already had a pool of skilled personnel, we deployed them quickly to respond to the outbreak of Ebola. One important aspect I would like to talk about is, or I would like to mention, is the issue of contact tracing. Contact tracing is very vital in the control of highly communicable diseases like Ebola. And you don't joke with it, you have to use skilled personnel for it. We use trained epidemiologists that know that we have to stop the transmission of this disease.
A key factor in the response was data management, which was managed by Mr. Tom Abba, supported by the WHO, CDC, eHealth, and other partners to ensure that the data quality and completeness of cases and contacts was excellent. Tom coordinated the development of smartphone-based platform to ensure that the case investigation, clinical, including lab data and epidemiological data, was captured and updated regularly. Contact tracing teams were also assigned Android-based phones that they used to register and monitor all contacts. Contacts that developed symptoms were automatically triggered messages and alerts to the team, as well as the case management team for immediate swift action.
when we got on board, it was difficult for people to actually get data in, because everybody was going out with the forms. They fill out the forms through the traffic and all that to get the forms back to the EOC for reporting. But then we had to think about ways to create a system so that they can send this information almost real time.
I think the presence of FELTP allowed Nigeria to really do marvelous work in terms of how Ebola response should be. One of the cardinal points in Ebola response is effective contact tracing. Anybody who comes into contact with a symptomatic Ebola case should be followed up for 21 days to detect Ebola symptoms as early as possible and remove them from the community. That was the difference between the three other affected countries and Nigeria. FELTP, working with WHO and the government, had a robust contact tracing team that ensured all the contacts were identified and were followed up every day and reported to the EOC every day.
When we were starting in FELTP, we knew we were building a high caliber workforce that is going to respond to epidemics, that are capable of data management, surveillance, evaluation, and issues like that. But we never knew that we were doing that one day we will have an unusual epidemic in our hand. Nigeria FELTP rose to the occasion in that if you look at those who responded, residents from Nigerian FELTP, residents and graduates, formed the majority of those who responded to this outbreak. The difference between Nigeria and countries like Guinea, Liberia, and Sierra Leone is because we have the workforce. Though we were keeping the workforce for the usual epidemic outbreaks within the country, not knowing that an unusual one will come and we will still need the same workforce. So we deployed them, and they formed the majority of the workforce that we deployed. Our response was swift. Our response was very, very successful.
Whereas WHO recorded a total of 23,729 cases and 9,604 deaths in West Africa as of the 22nd of February 2015, Nigeria, on the other hand, recorded 20 cases and 8 deaths and managed to contain the outbreak in the shortest period with no further cases. On the 20th of October 2014, Nigeria was declared free of Ebola.
My personal experience is everything boils down to a miracle, because I was positive, even when I knew I was faced with death. But at that time, I was positive about my situation. Because I was saying there was no way I'm going to die. I was having the symptoms. I have every of the symptoms. I think on the 3rd or 4th day before the government came and picked me to the isolation ward. So I was there in the isolation ward for 7 days. I was kept because they have what they call the suspect ward and they have what they call the confirmed ward. So I was in the suspect ward for a day. They took my blood sample, and when they took my blood sample, they came back and said I was positive. So they took me to the confirmed ward. But at the time, the result wasn't clear. So they brought me back to the suspect ward. We do the test again, and the results still came out positive. They now took me back to the confirmed ward. That was when I was confirmed Ebola positive. And after some days, I was there. I was still doing my normal thing because I was still telling them I'm not sick, even though they feel I have Ebola. But I was positive about the whole situation. And well, they did a marvelous job. Because in fact, that was what encouraged me to allow the government to come and take me.